You all already know that retinoblastoma is the most frequent primary ocular malignancy in children, and that it can be cured and survival is close to 90% in the of this disease is quite complex, as it can be a conservative or not a conservative approach. As you all know, enucleation is still a valid option for the most advanced retinoblastoma, and sometimes adjuvant chemotherapy is needed according to the pathology risk factors. Dr. Shields already gave a very beautiful overview of possible chemotherapy treatments, especially using intravenous chemotherapy, which were the standard of care since 20 years. They give a good long-term control, but unfortunately there were failures that occurred in the most advanced cases. That's why at the beginning of the years 2000, there was a strong need for even more effective therapies that could be associated possibly to less side effects, ocular or general. So selective ophthalmic artery chemotherapy or intraarterial chemotherapy was one of the options that was possible, that the technique improved and developed at that time. The real initial results were very interesting, but at the same time, many questions arose in number of the drugs used, the doses, the number of procedures, but also the toxicity, either ocular or general, and the impact on survival and on visual function. That's why we went on this technique, and Raphael will do a brief short history of the technique for you, and then describe how we do in Paris.
Thanks. Effectively, everything started in Japan because culturally there was a very difficult, a lot of difficulties in the tolerance to enucleation. So first tests were performed to inject directly inside the carotid artery using a balloon to occlude the carotid artery and inject the drug in the ophthalmic artery. With the development of the techniques with new microcatheters, small tubes that are able to navigate directly in the ostium of the arteries, we were able in the beginning of 2008 to super selectively inject the chemotherapy directly inside the ophthalmic artery. So this is called the selective technique of injection. It was presented first with Dr. Abramson and Dr. Pierre Gobin team. The goal, as have been previously said, is to decrease the rate of enucleation and lower the global toxicity of IV chemotherapy, and maybe also decrease secondary neoplasm or limit the risk of metastatic disease. So we started our first procedure in 2009, and it took us some time to get really confident with those small babies and specific techniques and navigation to now perform this technique routinely. And we were discussing with Mrs. Shields that in the beginning, also in their experience, it took a lot of hours to be ready to treat the patients. But now it has become much more routine, and we have gained a lot of experience, both in the technique for injection, but also in the global management of the patients in our operating room. Also, we have been together with Creil developing a prospective randomized controlled trial, and Dr. Lumbroso will present the results of this trial. A lot of importance has to be dedicated to the planning of the treatment and the preparation of the baby, because preparation is extremely important. The access, the arterial access, femoral access, or now in some cases radial access, still remains very tiny in those little kids. So we have to be very precise in the puncture of the arteries to get access. Also, navigation in those kids is quite easy, but the cannulation, the selective cannulation of the ophthalmic artery might be tricky. We have then to find ourselves in a perfect position so the drug is delivered inside the ophthalmic artery. And also the dosage of the drug is important. And we will repeat the cure mostly around 3 times with an interval of 1 month in between each session. So this is a carotid artery. The nose is in the right of the artery, and you can see the navigation here of a very tiny wire and a microcatheter that get inside the ophthalmic artery. This is the supraselective injection of the ophthalmic artery. And you have the choroidal blush, that is a surrogate marker for some diffusion of the drug inside the central retinal artery, which is the main feeder of the tumor. So we never see, because it's so tiny, the central retinal artery, it's very rare to be able to see it, but we take this choroidal blush as a surrogate. We are in a correct position. In some instances, we cannot directly access the ophthalmic artery, and we have to navigate through alternative routes. And mostly this route is the middle meningeal artery, which is a branch of the external carotid artery. And through this collateral circulation, we are able to opacify the choroidal blush and the globe, and we are able to inject the chemotherapy supraselectively. This is a schematic drawing. You have multiple collaterals that allows us to access to the ophthalmic central retinal artery, but it's collateral pathways, and we have to manage this in the rate of infusion and the dose of the drug. Also, sometimes cannulation of the ostium of the ophthalmic artery, because of specific angulation or bending, is not possible from the carotid artery, and we have to navigate the circle of Willis and go from the basilar artery, that is more posterior, through the communicating artery, up to the ophthalmic artery. One of the specific management I discuss is the preparation and planning of the treatment, because during the procedure, some complication might happen. Most of them, and the most important of them, is bronchospasm. When you have the cannulation of the ostium of the artery, it can sometimes trigger a specific reaction with a severe bronchospasm and a huge desaturation of the patient. So this might be prevented through correct anesthesiologic management. Then we might also face problem at the access, and we will also discuss the post-operative risks of complications that in some instances still need to be evaluated. This is, as I mentioned, the most frequent bronchospasm. You have to be aware of that when you start your practice, and it can be prevented. And we have published on that with our colleagues anesthesiologists, can be prevented by a strong management of the anesthetic and the depth of the anesthesiology that can prevent. Complication also at the approach. This is a publication from the group of Mrs. Shields, and Pascal Jabour is the interventional radiologist, a neuroradiologist there. So we have to be very cautious when we puncture arteries and to lower the potential loss of blood. Finally, catheterization, as you can see, we are at the ostium, and at some point, we might have some leakage of the drug outside of the ophthalmic arteries. This has no risk of complication on the brain, but it's something we particularly scrutinize in order not to happen. Lidia, I will now leave you the speech.
Yes. We do intraarterial chemotherapy since 2009, but in order to answer to all the questions we already mentioned before, we did design a phase 2 prospective non-randomized trial for this treatment, for first-line treatment, and the objective was eye preservation superior to the historic data of children treated with IV chemo. So the secondary objectives were complications and the measurements of the DAP. The inclusion criteria were patients aged from 6 months to 3 years with no prior treatment, with unilateral groups B, C, or D. We, on purpose, decided not to treat bilateral cases because at that time, there were beginning of description of severe ischemic complication after this procedure, and we were concerned about the visual function. Of course, we seek the consent of parents and tutor, and we excluded group E eyes. So the procedure is the one that Raphael described. We used in that protocol one drug, which is melphalan. All patients are evaluated in ophthalmologic ocular department here in Creil, and the intraarterial procedures done in Fondation Rothschild. The doses chosen was 0.4 milligram per kilos, which is quite classic. We never exceed 5 per injections for 1 to 6 course maximum, and we add local ocular therapy from the second or first, after the first or second, according to the tumor volume. So we included in that study 39 patients prospectively, and 36 could be treated. 2 patients could not be catheterized, and 1 patient could not be treated because at the moment of the diagnosis, he presented with a conjugation to general anesthesia. He couldn't be treated by intraarterial. Median age is quite classic for RB, and they received a median number of cycles of 4. Median follow-up is now of more of 5 years, and the majority of patients also received the eye treatment. We had to stop the treatment in 5 patients. In 1 child, she's presented with a very severe reaction during the procedure, so we decided not to continue with this treatment, and 2 for ocular complications. At the end of follow-up, the survival is excellent with all children alive and well, and ocular preservation at 5 years on the 36 treated is 69%. This is the Kaplan-Meier curve. When you look, and this is a case that fares well with a nicely regressed RB, but the problem is the vision because the lesion is posterior. So, at 18 months, 74% of children had their eye preserved, including the 3 eyes that were considered failures. And when we look at the 36, nearly 80% were preserved. The relapses were observed for a few children, and many of them led to enucleation. We decided never to treat these children with external beam radiation. Eye preservation, according to IRC classification, was excellent for the B and C groups, less good for the D groups, as we could expect, with 53%, which is better than the IV rates. So what is the tolerance and side effects? We had no real severe neurologic accidents in that series. Systemic, we observed a few cases of neutropenia, but never aplasia and never need of transfusion. We did observe ocular side effects, most of them not severe, even with eyelid periocular edema. We observed 2 very complete and severe ptosis and 2 cases of severe retinal ischemia. As a late side effects, we also see some iris atrophy, some massive choroidal atrophies, retinal detachments, and intravitreal hemorrhage. So here is a case of this patient that presents with a regressed retinoblastoma with but a completely atrophic fundus and no vision. So this ocular vasculopathy or retinal ischemia was seen in 5 patients on 36. The risk factors are not very well known. We speak about ophthalmic artery diameter. What is the physiopathology? Is it an endothelial lesion with the catheter? Is it a toxic effect on the endothelium of the vessels? Can be a precipitation, we do not exactly know. But the results are comparable to the other series in terms of ocular complication that could potentially threaten vision, such as retinal and choroidal ischemia. So there are still many unknowns on the long term. What is the visual function? What is the radiation-related toxicity? We should know that our DRP shows doses that are below toxic levels, but these children are very young, so it's possibly characterogenic. What is the impact of this shift of trend of treatment on metastatic disease? We hopefully did not observe none in this series, but the fact that they do not have IV chemo could lead to the lack of control of potential metastatic disease. So we begin to observe that series relate metastatic events. So it is important to select your patients and not to treat conservatively too advanced cases. What is the impact on secondary neoplasm? We do not really know. The series of from Japan shows a cumulative incidence of nearly 6%, but these patients were treated heavily and also received external beam or systemic chemo. So in conclusion, in our experience, the selective ophthalmic artery chemotherapy with only melphalan is an effective and safe first-line treatment for selected cases of RB. It does allow a better eye preservation even in more advanced groups, but ischemic complications are possible, so late visual function is not necessarily good. Is it possible to further improve the eye preservation? Well, we will try. We are now ongoing a trial or a prospective randomized trial using melphalan alone versus melphalan and topotecan to see if adding the topotecan will improve this result. It is important not to forget that the threshold between enucleation and conservative treatment is constantly evolving and that more and more children are treated conservatively, but unfortunately, some metastatic deaths begin to be described. So you always need to evaluate the balance between the benefits and risk from the treatment burden versus the results. Never forget that these technique needs multiple procedures, multiple general anesthesia, and sometimes will lead to a non-functional eye. So it is important not to forget that increasing the eye preservation is important, but with maintaining the excellent vital prognosis that we observe in the Occidental countries. Thank you. And it's important also to acknowledge all the group of Institut Curie and Fondation Rothschild. This is a disease that needs a multidisciplinary approach. Thanks to everybody.